Someone can, if someone can confirm that you can see it, I'll go ahead
We
and.
can see it, Lori. Thank you.
Fabulous. Thank you very much. So today, I'll be talking about EPSDT, early and periodic screening, diagnostic, and treatment, but from a health equity perspective. One of the ways that we work to connect with our members is taking a closer look at not only the information that we have and that we've collected about them as a managed care organization, but we also work to get just kind of a wider view of social determinants of health in the communities from just kind of a geographic perspective as well as a demographic perspective. So today, we're going to talk about how you can inform and impact your improvements around EPSDT using SDOH and community level data. One second, let's see, there it is. So this is me. Thank you so much for the really nice introduction. My name is Lori Payne, and I have actually been supporting culturally and linguistically appropriate services and health equity at ACLA since about 2017. I've supported and led projects that led to multicultural healthcare distinction for the National Committee for Quality Assurance, and ACLA, among other markets in the AmeriHealth Caritas enterprise, are also preparing to begin the process to achieve health equity accreditation, which is now which is going to replace the MHC distinction. This is kind of a quick rundown of what we'll be talking about today. I'll tell you a bit about our program. We're talking about our barriers, how we look at barriers to care, our own approach to improvement. But as a provider, it's really important that we get feedback from you and hear your thoughts around health equity and the challenges that your service populations may kind of face in achieving that status. We're going to talk about data connection analysis and what we like to call a 360 view of our community needs. We're definitely going to go over the tools and training that we share with our network providers around providing equitable care. And then, of course, there'll be time for the questions and the discussion. If you have, any questions while I'm talking or a comment, I really strongly encourage you to go ahead and participate. If you want to put something in the chat box or raise your hand, we will be monitoring that and we'll be responsive as they come up. Our disclaimer before we get into it is that this content is presented within this training for informational purposes only and not intended as medical advice or to direct treatment. Physicians and other healthcare providers are solely responsible for the treatment decisions for their patients and should not use the information presented and accompanying materials to substitute independent clinical judgment. So one of my favorite illustrations of what health equity looks like is the image to the right of your screen. On the top image, you can see everyone has a bicycle. There's definitely equality, but health equity asks us to look a little closer at our service populations and see, really what kind of bicycle do they need to actually complete the journey to health. And we do this through coordination and collaboration with, of course, our members. We talk with providers like you. We adhere to local and state government requirements. We also work with community-based organizations and other contracted managed care entities to really impact health disparities at a population level. Our work is to ensure the efforts are addressed and improve equity, also reduce disparities and improve cultural competence, but making sure that those efforts and those strategies are designed collaboratively. Also, we make sure that any lessons that we learn in carrying out those strategies are incorporated into future decision-making, more of the plan, do, study, act approach. Some of the barriers to care that we understand about our communities include anything that restricts the use of health services by making it more difficult to access, use, or benefit from care. Now, that can be transportation, provider availability, and things like that. Also, social risk factors associated with language, sexual orientation, gender identity, as well as culture. Each of these items, when taken separately, can provide a barrier to care. But as we know, a lot of community members across Louisiana are dealing with one or more of these issues and just kind of really having a hard time staying on top of their care plan or even carrying out preventive care processes that prevent long-term conditions from occurring. We look at the three, I call it the holy trinity of health equity, and that has to do with enrollees, providers, and community-based organizations. It's important that we develop bi-directional relationships with all of these groups based on the improvements that we want to see. Some of the things that we're doing right now to achieve equity is, of course, member engagement that is culturally cohesive. We work regularly through our Enrollee Advisory Council to ensure that member feedback is incorporated into the way we outreach to members, the way we communicate with members, as well as the way that we design programs. Because you can have, a great program on paper, but it's really important to run it past kind of the end users to make sure that you're really, kind of addressing and communicating in the way that's most effective. Of course, we work with providers doing educational sessions. We do share best practices that we learn through provider discussions, and of course, direct access like the discussion that we're having today. We work with community-based organizations to develop a bi-directional partnership that supports community engagement with the planned programs and services that we offer to address social determinants of health. We work with standardized communications to keep community-based organizations kind of in the loop in terms of the programs that we're offering in their areas, as well as, again, the programs that are gonna help meet the needs that are kind of outside of their service offerings. We also work with our community-based organizations to develop best practices. It's great when everyone is on the same page, and bi-directional relationships kind of depend on an agreed upon set of practices. So now I've kind of told you all about who we are and kind of what we do at ACLA. Would the participants on the call be open to talking about the kind of care that you provide, as well as the parishes in your service area? Feel free to use the chat box, or if you want to come off mute, just kind of tell us a bit about you. And this is, if you'd rather not be specific, if you can talk about the service areas, that is also sufficient. No worries, we'll keep it moving. If during at any point you want to kind of jump in, we do welcome your participation. So these are some things that we always ask our providers to consider when talking about equity. If you're looking at your patient population, think about the physical, social, and economic conditions in your service area that support health equity or a healthy lifestyle. Think about, the areas where your service populations live. Are there parks? Are there grocery stores that provide healthy meals? Is it easy or difficult for them to actually get to a provider to receive health care? And what kinds of gaps have you noticed in the communities you serve? Are there any barriers to care that your service populations are facing? And consider what would motivate you to make equity a strategic priority. And of course, how can AmeriHealth Caritas Louisiana support your practice in providing equitable care? Now, just as we walk through the information on the slides that are coming up, just kind of think about these questions in terms of, your patients, where they live, and the things that you understand about them in terms of the challenges they face. Thanks, Shannon. So I referred earlier to our kind of 360 approach to data collection, analysis, and action. Internal data, there is an abundance of it, and we rely on it greatly to develop interventions and improvement programs, as well as outreach strategies to really reach the member demographic that we want to touch. So we use information around member demographics like race, ethnicity, language, age, which is really a key component for EPSDT, the age. But we also look at the geographic location of our members, because as we know, people in rural areas have different challenges in terms of accessing healthcare than people in urban areas. An example would be the presence of public transportation. That's kind of a huge one for members in rural areas. And then there are social risk factors. And the social risk factors are something that is more specific to a household, right? Um, the SDOH may affect the entire community, like presence of parks, the presence of providers in the area. But then social risk factors include things like language, right? Specific things that are particular to a household. Food insecurity is a social risk factor. We look at gaps in care. We constantly track our member adherence to care requirements associated with any chronic conditions they may have, as well as preventive care visits that should be carried out. We look at claims data, of course, HEDIS outcomes, and we do collect a lot of feedback directly from our enrollees through surveys. We do health needs assessments. We do CAP surveys, which encourages our members to share their experience working with us as well as with our providers on a general basis and see what their score is. We take the information from those, and this is how we decide which areas we want to select for improvement. Now, in terms of developing that improvement approach, community level data from external sources really kind of illuminate the picture of the challenges that our members are facing in getting care. So we use things like the census. If we find that our internal demographic data may be missing or could be supplemented, we use county health rankings, which we'll talk about later. The community health needs assessments, which are done periodically by health organizations and nonprofits. We also refer to the Asset Limited Income Constrained and Employed Index. It's called the ALICE Index. And what the ALICE Index does is kind of tell you the density of the working poor in a specific geographic area. Let's see, there is some information in the chat. Oh, your responses will not be recorded. Thanks, Wendy. And then, of course, we look at the Louisiana State Health Assessment. The Louisiana State Health Assessment is a tool that the Louisiana Department of Health has developed, and there is a huge equity component in that. And we'll talk more about that in ways that you can use it in the next slides. So the County Health Rankings and Roadmaps is done on a regular basis, and it essentially looks at different aspects of health habits, behavioral habits, and community exposures that affect health outcomes. There has been a decline in life expectancy for rural communities over the past 10 years, based on County Health Rankings data. There are areas of special interest in the Deep South, which is where many of us, well, essentially all of us on the call may live and work. So the information and this sort of thing will really give us some insight into the needs of the communities. We also learned that social and structural factors play a critical role in the community health and health equity, and it accounts for as much as 47% of health outcomes. That is when compared to clinical. Compared to clinical practices as well. I've seen studies that show that number 47% to be even higher. So what this tells us is that there's as much as you can do in your office to ensure health equitable outcomes for your patients. There are things that patients deal with before they even get to you that affect their outcomes as well. So this is really why we're focusing on social determinants of health and social risk factors. Because what we have found is that 47% of health outcomes, that also includes maternal and mortality rates. So it's really across the board of all ages. Are there any questions so far? So the map that we're seeing here is are the health outcomes, and this is based on information from the most recent county health rankings. These are health outcomes and factors, and they are broken out or kind of grouped by parish. Now, the red parishes on the map represent rural areas, and the non-colored areas are those designated as urban. So we compared the county health rankings for Louisiana and kind of mapped it out to help us to identify the areas where they may be facing more challenges in staying healthy. And what you can see here, the number 4 on this shows areas that are least healthy according to county health rankings. And as you can see, all of our forests for Louisiana are in those areas that are designated as rural. Is there anyone on the call? Are there any providers on the call that service areas that are decidedly rural, um, either based on the kind of lay of the land or any census designation? If you are, you've probably talked to your patients and talked to your members, at the point of care about any challenges they are facing. And what we've also learned in provider discussions is that there are offices who use their own resources to kind of help their patients address social determinants of health. But looking at it from a geographic perspective, kind of a bird's eye view of state outcomes, what we're seeing is that, rural communities are really having a rough time in terms of staying healthy. And this includes length of life as well as quality of life. And so an awareness of these, and specifically the parishes, where these needs are, can help you to prepare and maybe inform the conversations that you have with members about their challenges, or perhaps maybe ask them some questions about their own factors and their health habits. This information is available online. It's free to review, and the links to this data is provided in the presentation. The next item that we look at is the ALICE index, right? Also mapped out, the asset limited, income constrained, and employed. And again, this is essentially a map of the working poor, right? 33% of households in Louisiana are ALICE households, meaning 33.2% are members of the working poor. And as you can see, the density of ALICE households is shown by the darkness of the color of the parish. Now I can bring this back up. We compared these outcomes to the prior map, and as you can see, there is a lot of overlap in these areas. So if you're working to develop an improvement and you really want to make an impact, you take all of this information and you put it into your strategy or the way that you approach working with these communities. Because even if they haven't expressed to you directly what challenges they're facing, this sort of information can help you glean and kind of prepare for it, and just kind of assume that somebody's going to be dealing with these issues. So if you look at the asset limited, income constrained households, and you live in a parish where there is deep density, right? At least 42%, right? Then you know that populations in these areas, yes, they may be on Medicaid, but there's a good chance that they're also employed. So you know that they have to work, and you know that that's probably going to make it difficult for them to get time off to see the doctor. And the time that they are off automatically may not align with your office hours. So there's a question, like, how do we address that? How will you address that in your practice? Could you maybe find out of any other providers in the area that have extended office hours and refer them to that place? What we try to discourage among our membership is the usage of the ER for like regular visits. What we find is that people who are working, members of the working poor, do not generally have time to go to the doctor. And so if there is an issue, people tend to wait until they actually either can't fix it at home or realize that it's too serious for them to address. And then they end up going to the emergency room, as you know, because the symptoms are really just unbearable at that point. But if you know that this is the type of situation that your service population is facing, as a provider, how can you consider that in the way that you communicate with patients, or maybe how you support them and actually getting to the doctor in a timely manner. And again, this is, not advice. The purpose here is really just to provide information to you, really to consider. In terms of children, we look at early and periodic screening development and testing. You look at the children and you look at their living situation, and you understand that adverse childhood experiences affect the likelihood of young patients actually following through with their preventive care or immunizations or screenings like autism or anything like that. Children who are having adverse childhood experiences tend to be less likely, right? And then ACEs could be anything from violence in the home, abuse, homelessness, or exposure to family members with mental health or substance abuse problems. All of these issues are linked to chronic health problems and mental illness, substance misuse in adulthood, but there is a direct effect on on children who are experiencing this in real time. And based on the most recent survey, almost 60% of Louisiana adults reported having experienced one or more adverse childhood experiences during their formative years. So if we take this, we can extrapolate that about 60% of kids right now are probably going through the same thing. So if you look at that, it really makes you take a second look at the likelihood of these kids and their parents making it to the preventive care appointments or following up on care plans and things like that. These are real challenges. And how do we as providers and managed care organizations help these families address these issues? I have to say, this information surprised me as well. I have to say. Another adverse childhood experience would be the incarceration of one or more parents. The Southern Poverty Law Center has put together a really interesting report on the children of incarcerated parents in Louisiana. But nationally, 1 in 28 children today have a parent who is incarcerated. In 1985, that number was 1 in 125. So what you're seeing is clearly more kids with incarcerated parents. Now, it doesn't mean that there isn't a parent in the home, but the parent that is there has all of the responsibility. And there may be some gaps in support to making sure kids get their immunizations or their screenings on time. And as you can see, national outcomes show that 11.4% of Black children have a parent who is incarcerated, compared to 1.8% of their white counterparts. So if you live in an area that is rural and that has high African American population, you can say that, you can make assumptions about the difficulties that some of the parents may be having in getting their kids there. Specifically for our state, an estimated 94,000 children have a parent who is incarcerated. Are one of those kids being serviced by you? A lot of times we find that kids in these situations, the grandparents kind of take up the caregiving responsibilities. So then if that's the case, then, what are the challenges that the grandparents are facing? Is the communication going to the grandparents' house, or is the communication going to the parents' house? These are all questions that, we can ask our members or our patients at the point of contact to make sure that whatever information from the doctor's office is kind of getting to the correct person. Maybe there's an issue of setting up the paperwork to make sure that the grandparent is included as the main contact or the caregiver for the child. This kind of, addresses maybe the barrier to information that may be a cause of this. And of course, the last topic is that African American represent over 2/3 of the prison population in Louisiana. So now that we've kind of talked about, what we do in terms of health equity for the different, for the different core stakeholders and some of the things that kids in Louisiana may be facing in terms of accessing EPSDT treatment. One of the ways that we engage with providers is the conclusions that we've come to in terms of reviewing this information. And we incorporate this into the way we engage with providers. That means giving you materials that are going to help you with insight into your service populations. We share information on a regular basis in the provider post um, in terms of health equity updates and additional tools that we may have. And of course, our account executives send informational emails to providers on a regular basis, depending on the plan initiatives, and anything that is pertinent to delivering equitable care. There are wellness days that we incorporated. We do work with rural health centers to make sure that they're aware of all of this information. And of course, there's areas that are targeted for information for populations that are within their service area. And a lot of times we'll send targeted educational materials to providers, like we were talking about earlier, in rural areas, giving them an overview of the demographic makeup of the populations there. Anything that we can give to you to kind of help you support and kind of anticipate the needs of your service population. These are the things that we do. And of course, direct access discussions. We do have a recurring provider advisory council meeting that we hold at the plan. I encourage you all to kind of register when the invitations do go out for 2024. And of course, tele-echo sessions like the one right now. We do provide talking points for our account executives to kind of keep you guys, in the loop. We provide equity training that is facilitated via web. It's once a quarter, and there's more information about that later on. And of course, collaboration opportunities. Again, if we can make it work with providers, only if providers tell us, really what would support them in achieving health equity with their service populations. So the feedback that we get from you, the challenges that you face, information on things that have worked for you in terms of getting members to the office, these are all things that we want to know, because if it works for you, we may be able to scale it to our entire network and really, just show improvement across the board in that respect. Are there any questions about what I've shared so far? So this is some information on the tools that we currently have in place to help providers address social determinants of health and social risk factors. There is a provider HEDIS report card that is available to providers. It has granular level information on patient adherence to care plans, preventive screenings, and things like that. What we've also added SDOH data to those report cards. So if you have a patient, you can see whether or not they have communicated, or if there's a health literacy concern for them, if they have communicated to us that they have a transportation issue for getting to appointments, if they've shared a housing status concern with us, or if there is food insecurity in their household. We collect information on patient needs for SDOH through health needs assessments and SDOH screenings. So when a patient does, communicate these things to us, and that patient is your patient, it will be in the provider HEDIS report card, and it'll give you, again, additional insight into how best to make sure that they come in for their appointments on time and on a regular basis. We provide non-emergency medical transportation for our members across the state. So those in rural areas, they can address this barrier with that. If transportation needs to be arranged, there are instructions for doing so. We also provide interpretation services. This is free of charge for members and providers. It can be delivered telephonically at the point of service, or you can have an interpreter come and do in-person interpretation services at your office. What we have learned is that our Hispanic members do prefer an in-person interpreter for them. I think it just kind of helps the conversation flow, and there's not a phone in between them. So that's one. And then, of course, the Let Us Know form. The Let Us Know form is a tool that we give to providers so that you can also discuss SDOH challenges with your member with your patient and kind of match them up with programs and services that we provide that address that barrier. And so the next slide, we're going to talk about, information that is on that let us know form. So this is a member intervention request form. It's available for download from our website. It can be, we have an English and Spanish version of this form, depending on the language needs of your member. But on the right side, you'll kind of see where we blew out all the small text from over here. And you would simply need to add in information on the member, your information here, and then, once you talk with the member, just kind of see if each of these things apply to their situation. If there's transportation needed, if they need housing resources, education and employment, if you have identified that this patient has frequent emergency room utilization, maybe they need education on plan benefits and resources that we provide. This is something that you can use to connect those members to these things that we offer to kind of help ease the load or address some of those barriers to care that we talked about earlier. There is a Bright Start Maternity Program, translations, durable medical equipment, things like that. Sometimes they need a behavioral health provider or some other sort of specialty provider. All of these items are on the Let Us Know form. And if in your process of using this form, you identify something that maybe we should include to be tracked or addressed with members that isn't on it, let us know as well. There's a place here at the bottom for additional comments, and this is where you will put that information. What we've also done is updated our provider change form. What we have found is that a lot of providers, while they are willing to share information about their language or the language of their staff, a lot of people, providers, have been a little hesitant to provide information on their race. And we're kind of getting to the bottom of why that is with the intent to address it. But for now, we have increased the avenues with which that you can use to update information on your race, ethnicity, and language in your practice by using our provider change form. You can go to our website and update any information or add it if you haven't had a chance to do so. Add the information in the form and return it to us, and we will update your record based on that information. If you have any questions about the process, you can definitely reach out to your account executive to answer any questions that you might have. Another tool that we give providers is Find Help Support. Now, Find Help is a partner website that is designed to assist with social determinant with SDOH issues by connecting members with community-based organizations that are in their database. FindHelp.com is a search platform where you can type in your zip code and find community-based organizations in that area. But then you can also filter out your search. If you know that, your patient is looking for housing needs, for housing support, or transportation or financial assistance, you can filter your search on Find Help to actually connect your patients with that community support. It's something that we encourage. Our community education team uses it. Our rapid response team uses it. All of our member-facing associates actually use this in the event that they have a need that is outside of the services that we provide. And we highly encourage our providers to kind of take the same approach. Are there any questions about these two items? A communication tool that we have for you guys to address social risk factors, again, the interpretation service. It's free. You can get it, as I said before, telephonically and in person. What you're seeing right here on the right is a flow chart that you can use to access our free interpretation services. I will say that there are members and patients who prefer to have a family member in the office with them, doing the interpretation for you. But the danger in that is that their family member may not be versed in the vernacular of healthcare and healthcare delivery, and some of the issues may be lost in that translation or in the interpretation process. So We always encourage our members to use our interpretation service. However, if they do, you have to inform them that prefer that they use a professional interpreter. But down here at the bottom are instructions for how to actually connect with that. On the left side is a communication tool that we give to our members to kind of match up the interpretation flow chart. This is what you're seeing here is kind of a blown out version of it. It's in real life, it's about the size of a credit card, and our members can keep it in their wallets. And if they do need an interpreter, they can definitely just kind of pull out this card and hand it to your associate or the person at the front desk and say, hey, I need an interpreter for healthcare services. They can also use this at the point of contact if they are in an emergency situation. It kind of helps them to kind of get that out and be super clear about it. And it says here that they're an ACLA member, so it lets you know that you can use our interpretation services in that interaction. This is what it says in Spanish, but this would be on the back of the card. So these two tools kind of go together to make sure that the chain stays connected for interpretation. So now that we've gone over kind of the larger external community needs, just kind of a review of things that impact community members and staying healthy and accessing care, I'll just kind of ask again that you consider these items. We do appreciate your feedback in the discussion, but you're not obligated. But my ask, I'll ask again, is that you kind of think about these things in terms of, how you provide care to your service population. What are the physical, social, and economic conditions in your service area that support health equity or a healthy lifestyle? And who has access to these conditions? What kind of health gaps have you noticed in the communities you serve? Are you seeing there are a lot of patients struggling with weight? Have you noticed, have you heard from patients? Have they communicated to you things that could be considered behavioral health issues? Are you seeing, a surge in people being treated for STIs in your community? And what barriers to care are your service populations facing? And again, that's either a social determinant of health or a social risk factor. If you think about that, how can you kind of arrange the way that you deliver care to make sure that those things are addressed? And of course, what would motivate you to make equity a strategic priority? What I can say is that sometimes there are provider reimbursements and provider payments for performance in terms of special measures around maternal health, specifically PPC. ACLA has implemented PQE payments for value-based providers, meaning providers with value-based contracts, meaning if you reach a certain level of member adherence to prenatal and postpartum visit requirements, you will become eligible for that PQE payment. There's more information in our provider manual, as well as any information that you want to reach out from your account executive about, how that works. And of course, how can AmeriHealth Caritas Louisiana support your practice in providing equitable care? These are things that we're asking you to consider. If you notice, kind of a trend among your service population where something needs to be done, let us know. We would like to know and work with you to explore ways that, we can support improvement in those areas. If you're interested in completing additional cultural competency training, you can sign up for our quarterly trainings that are delivered via web. And you can sign up on our website at the link here. And we have curated several other training resources specific to our service population that you can also access and complete at will. Just click on the link in the website, and there will be a list of selections from which you can choose. Are there any questions about the information